how do you decide if there could be like a superimposed bacterial pneumonia? And what is your antibiotic of choice for treating these patients in those cases?
I think time
Dr. Herb?
course, yeah, I was going to say, I think time course and clinical symptomology is really important. So, if this is day 2 of your patient's illness and their chest x-ray looks like they've got multifocal infiltrates, and they're testing positive for COVID-19, this is probably just a simple viral pneumonia. I think we start considering, just like with, any post-viral pneumonia, we deal with flu. Like, if you've been sick for a week, then we start thinking that maybe perhaps the lungs have been, severe, have been inflamed such that bacteria can move in, set up shop, and cause a superimposed infection. I would say that, and then also your imaging is important. If you have, a more prominent lobar consolidation, then I would be initiating antibiotics regardless of the day of presentation or the change in illness. But this is one of those moments where history is of prime importance. And the use of your clinical gestalt is also gonna play a role in, do I think this is just simple multifocal pneumonia from COVID-19, or does my imaging make me more concerned for a focal consolidation that I think is bacterial? I don't think there's really any lab markers that would be helpful. Some people will use procalcitonin in healthy patients. Procalcitonin has largely been negative in the population of COVID patients. And so some people will say, if I have an elevated procalcitonin, I'm going to concomitantly treat with antibiotics. But I don't know if that's necessarily a standard practice or studied with evidence behind it to support that practice pattern. I don't know, Dr. Rivera, if you have anything to add to that.
Everything that you say is right. A lot of these patients, they come and you measure procalcitonin is going to be negative, right?
Mm-hmm.
But again, if like you were saying, it's a question of knowing your patient, right? If there's a clinical change, right? They start spiking now fevers when they were not spiking fevers for days, right? If they're on the ventilator and you see a new influx, right? If you see there's more secretions, right? If your procalcitonin does jump, right? Taking all that into account, that you can decide to do, to do antibiotics, right? If they come from the community from the get-go, you can just do, your ceftriaxone, azithromycin, right? Just to be certain you cover some strep. Either be in the hospital now at least for more 72 hours, or they've been intubated now for, for a long time, that you have to worry about nosocomial, organisms, and you have to be a little bit more aggressive, right? Maybe cover MRSA with vancomycin and some sort of anti-pseudomonal, beta-lactam, either your, Sosine, cefepime, or something similar like that. But yeah, from the get-go, usually these patients don't need antibiotics, but they can definitely develop, nosocomial infections, more so in the ICU because of, their condition.